A lupus patient can occasionally come with neurological symptoms, and then the onus is on us to distinguish a neuropsychiatric lupus flare from a steroid-induced psychosis. And this is a real-world dilemma because the treatment and management pathways of these are diametrically opposite. A lupus patient develops agitation, delirium, psychosis, mood disturbance, and the question is it neurolupus flare or it's a steroid psychosis? How do you distinguish between these two? Because neuropsychiatric lupus needs more of immunosuppression, and steroid psychosis obviously need reduction in steroids, and misclassification can worsen the outcome. Now let's hair split how this can happen. Timing is the first clue. When was the steroid started or when was the steroid hiked? Classically, steroid psychosis starts after 1 to 2 weeks of steroid hike. While neurolupus flare has no definite relationship to the dose or the escalation of the dose. So steroid psychosis commonly appears 1 to 2 weeks after dose escalation. Now let's see the clinical pattern. Neuropsychiatric lupus, headaches are common, seizures can possible, focal deficit is possible, movement disorders are common, and not much cognitive decline is there. While cognitive decline can be fluctuating, and predominant psychosis and mania are seen in steroid psychosis. Delirium can be seen in both. So neurological signs favor neuropsychiatric lupus. Pure behavioral changes favors steroid toxicity. What are the systemic clues as to this is a neuropsychiatric flare? Active lupus elsewhere, cytopenias, serositis, and a renal flare all supports a neuropsychiatric lupus. So look for the systemic activity of lupus in all these cases. When present, favors a neuropsychiatric lupus. Immunological signals, yes, a fall in complements, a raising dsDNA, or presence of antiphospholipid antibodies of new onset are all suggesting that this is an immune-driven disease and it is a neuropsychiatric lupus. Steroid psychosis is mainly a pharmacological disease. Coming to neuroimaging, when an MRI is done on these patients, finding of white matter lesions, ischemic infarcts or vasculopathy all suggest a neuropsychiatric lupus. But one caveat is that a normal MRI does not exclude a neuropsychiatric lupus, but an abnormal MRI would support it. Now let's see the CSF findings. In neuropsychiatric lupus, there may be mild pleocytosis, mild protein elevation, and at times immune markers may be present in the CSF, but all these are characteristically absent in steroid psychosis. So CSF helps when the clinical spectrum is unclear. Always look for APS because an APS overlap can produce stroke, cognitive dysfunction, behavioral changes. So an APS overlap always favors a neuropsychiatric lupus flare. Check for antiphospholipid antibodies. Now next one is to response to steroid, and we all know that neurolupus will respond better to steroid, and steroid psychosis can worsen on continuing steroids and which actually need a dose reduction when it comes to steroid psychosis. Now practical bedside differentiation, how you do in neuropsychiatric, think of neuropsychiatric lupus when there are neurological signs are present, systemic flare is present, low complement is present, raising DNA titer is present, there are MRI abnormalities and there are CSF abnormalities. You can think of steroid psychosis when a recent dose escalation is there and it's pure mood and behavioral changes, no focal deficits, no systemic flare and normal complements. So this way you can distinguish between these two because the management is important. In neuropsychiatric lupus, you should increase the immunosuppression. If it is low dose steroid, increase the steroid or add cyclophosphamide and mycophenolate. In steroid psychosis, obviously, just to reduce the dose of steroid and add antipsychotics. So this is how this distinguishes of clinical importance. So in lupus, a new psychosis is not always disease and it's not always a drug. It could be either. So how do you differentiate? By the timing, by the systemic clues and by the immune markers. So this is how you should distinguish between these two.